Okay, good evening, everyone. Thank you so much for joining us tonight for prostate cancer, understanding causes, diagnosis, and treatment. Our speakers tonight are Dr. Jim C. Yu, MD, MPH. He's the professor of urology, a Ronald P. Lynch professor of urologic oncology at Weill Cornell Medicine, and an attending urologist at New York Presbyterian. Dr. Christopher Barbieri is an associate professor of urology, a Peter M. Sacerdote Distinguished Associate Professor of Urologic Oncology at Weill Cornell Medicine, and Dr. Timothy D. McClure is an associate professor of urology, assistant professor of urology and radiation at Weill Cornell Medicine, and an assistant attending urologist at New York Presbyterian. Tonight's session will be recorded and sent to all those who registered in the next few days. We encourage you to submit your questions in the Q&A section, and we will do our best to get to as many of them as possible. It is my pleasure to turn things over to Dr. Yu.
Thank you so much, Liza. So I am covering two topics. Dr. Douglas Scher was supposed to cover this first one, but he's actually traveling back from doing some surgery in the Middle East. So I'll start out by covering what is prostate cancer, and as well as talking about prostate cancer screening, and then of course my colleagues will cover the rest of the treatment options. In terms of, let's see, let me just get these slides to advance here. There we go. So what is the prostate? I think that's a very common question, and so anatomically, the prostate sits beneath the bladder. So I think one of the questions we already got surrounded BPH. And so as men get older, the prostate enlarges and it can create the symptoms of a slower urinary stream by virtue of that tube being squeezed, the urethra that travels through the prostate. And of course, the urine then flows out of the urethra. And in terms of the function of the prostate, it contributes to the man's ejaculate. It's necessary for male reproduction, and it supports sperm transport. In terms of endocrinologically, there's the conversion of testosterone to dihydrotestosterone. These are just hormones within the prostate. And as an indication here, one of the medications to treat that condition I referred to earlier, benign prostatic hyperplasia, that is to decrease the size, is to block an enzyme that converts testosterone to dihydrotestosterone. It's known as finasteride or Proscar, and in another dose, actually, it's minoxidil, which helps with alopecia or male pattern baldness. In terms of what is prostate cancer, and cancer in general is just unregulated cell growth, and in this case, it's of the prostate cells. And in terms of what are the causes of prostate cancer, well, age is the most significant cause. That is, the risk of prostate cancer increases as a man gets older. We also know epidemiologically that African American and African Caribbean men are at the highest risk for prostate cancer. Family history, for example, contributes. That is, first degree relatives who have prostate cancer, or there's associations, of course, or germline mutations that can be passed on, from BRCA mutations for breast cancer. As mentioned in the inherited or germline genes, there's ATM, MLH1, and we know that obesity also increases the risk of high risk or high grade prostate cancers and metastasis. This is, and I'll have a slide later that's similar, but it just gives a comparison of the most common cancers diagnosed in men on the left and women on the right. And so you can see that prostate cancer comprises about 27% of the cancers diagnosed in US men, as opposed to breast cancer being the most common in women. And in 2022, the incidence of prostate cancer, 268,490. The mortality, 34,500 men died from prostate cancer. As mentioned earlier, we see more aggressive disease in men of African descent. And in terms of the lifetime prevalence, it's about 1 in 6 US men. Specifically looking at this higher risk group of African American men, the incidence is 275 per 100,000 men. The incidence is 60% higher in African American versus white men, and 1 in 4 African American men will get prostate cancer, and more men are diagnosed with more advanced disease relative to non-African American men. In terms of the survival over the last 5 years has improved. and I'm sorry, 5-year survival has improved over the last 30 decades for African-American men. And 40% of prostate cancers occur in men under the age of 45 have a hereditary basis, or some of those potential germline mutations that we discussed earlier. And the risk of developing prostate cancer doubles for men with a father or brother with prostate cancer. In terms of other lifestyle changes or risk factors, saturated fat intake is associated with prostate cancer, as is a high red meat dietary intake. High soy intake may have a protective effect, and there's been randomized trials that have looked at vitamin E, selenium, and lycopene, which likely have no benefit in terms of decreasing the risk of prostate cancer. I'll shift a little bit now to the screening guidelines, and I'll start with looking at some of the historical trends in terms of diagnosing prostate cancer. So on the figure on the left, for example, it shows that the introduction of the blood test, the PSA, or prostate-specific antigen, really came about in the late 1980s and the early 1990s. And so you can see in the blue bar or curve on the left and bar that with the initiation and adoption of PSA screening in the United States, the incidence of metastatic disease, that is cancer that already spread outside of the prostate at diagnosis, dropped sharply. And that continued to decline really, and then it flattened out really in around 2004. And actually this has gone up in the last 10 decades, and it's thought to be because there was a backlash against PSA screening, and PSA screening, actually usage of PSA screening actually decreased amongst the primary care doctors and internists in the United States. It's a nice contrast. It shows here mammography for breast cancer, because we showed earlier that that's the most common cancer in women. But when mammography came out, there was really no change in the likelihood of finding cancers that had already spread outside the breast. And so you can see the different impact that PSA has had over time, and yet it remains controversial whether there's some benefit to PSA, because PSA resulted in overdiagnosis. And now turning your attention to the right, you can see that overdiagnosis occurs when we find things that look different under the microscope, that is different from normal cells, but these different cells that get the designation of cancer grow very slowly, so slowly that a man is unlikely to die from that cancer, and or it'll never cause symptoms. And so therefore, when you look at kind of the animals that are used as examples, these are the snails and the tortoises that never get to that dashed horizontal line. That is, they never reach a point where they cause symptoms. Now the bears, for example, in this analogy, or the aqua line, those are things that when diagnosed, for example, the vertical dotted line, you're hoping to find those before they cause symptoms. And in fact, they can be cured, because eventually it causes time. And then there are the hummingbirds, that is, those who are found cancers that are found when it's already too late. And so when screening doesn't detect a cancer that's already metastatic, and there are some instances, although very rare, of prostate cancers that have a very low PSA, so that by the time that it increases or it's abnormal, the prostate cancer is already metastasized. But by and large, we find that the majority of prostate cancers traditionally have been the low risk or low grade cancers, those that are the tortoises and the snails that don't cause any problems. But we'll see some of the innovations in which I think the overdiagnosis has decreased, and Dr. Barbieri is going to speak to strategies surrounding overdiagnosis as well. Just in parallel to what I showed earlier, where the y-axis showed the incidence of metastatic disease at diagnosis, here we're looking at the number of men that deaths per year due to prostate cancer, and as the bottom line, and then the top line is just new cases of prostate cancer. And so the new cases have declined over time, primarily because, at one point in time, for example, when I said PSA was introduced in the late 1980s, there was really no screening test until that time point to really find these prostate cancers that are just really the first sign is an abnormal blood test. Previously, these were either men who had an abnormal prostate exam, or they presented to the emergency room to their internist with a lot of weight loss, or really lower pain, lower leg or lower extremity weakness because of metastasis to the spine. But this just shows over time, since PSA became widespread in use in the early 1990s, that you can see that the deaths from prostate cancer have gone down from an epidemiologic standpoint. I showed some of these statistics earlier from Dr. Schur's talk, but just showing the trend, that is from 2018 to 2023, you can see that the incidence of the new cases per year of prostate cancer has increased. And the reason for this increase, as I alluded to earlier, is that in 2012, there was a national recommendation or what we call professional guidelines of experts that said, look, PSA should not be used. And I think increasingly the evidence is that PSA does have some benefit, although modest, as we'll see shortly. And then when we look at so in other words, the usage of PSA went down. Now it's going back up because of the pendulum swing back to PSA not being unhelpful. And then the deaths have been increasing over time. And it's not clear why, but some of this may be due to the fact that there was a 10-year period where PSA utilization was down. Alternatively, it could, as we said earlier, obesity is associated with, more aggressive prostate cancers. Is that something nationally that's happening? So I showed this study because this is a study that came from Sweden, in which there was a blood banking of men in their 40s, and the original study was to bank blood and then to look at what their men's subsequent risk of death from a heart attack may be. But in this case, because they had the blood stored, they could also look at downstream who developed prostate cancer and go back to their PSA levels from the blood that was stored when they were aged between 44 and 50 years, and see what the subsequent likelihood or probability of developing prostate cancer is. And so just taking you through this graph, for example, if someone had a PSA of 1 in their mid to late 40s, then their subsequent likelihood of developing prostate cancer was 10%. On the other hand, if that PSA was 4, then they're approaching a 65 to 70% chance that they're going to be diagnosed with prostate cancer before the age of 75. And so this is just advocating for the use of what's called a baseline PSA to see what your subsequent lifetime risk of PSA or prostate cancer may be. And one of the ways that this has been used, and this was developed actually by a collaborator of mine, Andrew Vickers, who is a very thoughtful biostatistician, is that from that and all the existing evidence, you can, I think this is the best way that PSA may be thought of and used. And then we'll talk about what the professionals guidelines say. And so, for example, if the PSA is greater than or equal to 3 for a man in his late 40s, then consider prostate biopsy right at that time point. If it's greater than or equal to 1, but it's less than 3, then return for PSA testing every 2 to 4 years. If it's less than 1, then return for PSA testing at 6 to 10 years. And then PSA testing should end at age 60 for those with a PSA less than or equal to 1, at 70, unless a man is very healthy and has a higher than average PSA at that time, or at age 75 for all men, because again, you're at an age where you're going to die with rather than die from a prostate cancer and or ever experience any meaningful symptoms that prostate cancer may have. In terms of, I mentioned if someone has an elevated PSA, it used to be that everyone would, or you could repeat the PSA, but then eventually you just have a prostate biopsy. Now there's been the evidence has shown that getting an MRI after an elevated PSA as a biomarker as another way to risk stratify to look for if there's something abnormal on MRI. And basically this study showed that if a man with an elevated PSA got an MRI, about a third of them could avoid a biopsy because that MRI was normal. And if something was abnormal on the MRI, then it allowed us to better target that suspicious area and therefore do a more accurate biopsy. So the MRI before biopsy increased the detection of what we call clinically significant cancer, and I think Dr. Barbieri will speak more to that. But those are the bears, if you will, the indolent prostate cancers, or the tortoises and the hummingbirds, and it decreased the detection of those, which you don't want to find. So getting now to what the recommendations are, and so I should mention that why is this infographic? Why does it say screening for men age 55 to 69? Well, it's because there's only one randomized controlled trial that has looked at this that was high quality, and the entry criteria or the people that were selected for that trial were men aged in this range. And so we don't really know what the long-term benefits of PSA screening are. But if you look at this, and again, some of the limitations of this infographic was that this follow-up for this study was about 13 years. And so when you see the net benefit of 1,000 men being offered PSA screening, and then at the bottom, 3 would avoid the cancer spreading to other organs, 1 avoids the death from prostate cancer, 5 die from prostate cancer despite treatment. This is at a median follow-up of about 13 years. And when we follow men out to, for example, 20, 25 years, the benefit becomes much greater. And so, but having said that, reflecting back on what I said earlier about the more thoughtful use of PSA screening, for example, most men should stop at age 70, or if someone's healthy, they should stop at 75. Again, it's because the numbers at the bottom, that is the benefit of PSA, the number of men who avoid death from prostate cancer, that number goes down significantly because of the competing risk of dying from other things, such as heart attacks, strokes, natural causes as a man gets older. So, and then Dr. McClure, of course, is going to talk about treatment and some of the ways that we can reduce the morbidity of treatment. So let me stop there and turn it over to my colleagues.
Yeah, so I'm happy to take over. Thanks, Dr. Hu, for that a terrific summary of some of the initial causes and screening. And so I'm going to talk about active surveillance for prostate cancer. What is active surveillance, and how can we really use it to get the best outcomes for men? There we go. So, I mean, Dr. Hu gave a very thoughtful description of how prostate screening works and how it can work. And so really the focus is, well, then what is the potential downside to screening? And as he alluded to, what has been brought up many times by the critics of screening is the downside of screening is the idea of overdiagnosis. It's finding cancers that you really don't need to find because they grow so slowly that they're never going to hurt a man during his natural lifetime. And, at least 50% of men who are diagnosed with prostate cancer have very slow growing disease that fits into that category. And if those men are diagnosed with these cancers in the past, going back 20, 30 years, those men would have been treated for those slow growing cancers because, quite frankly, as a field, we didn't know enough to recognize that they were as slow growing as they are. That would have led to what's called overtreatment. So aggressive treatment with surgery or radiation or other treatments of cancers that are never really going to hurt a man, and therefore unnecessary side effects to that man. So the idea of active surveillance, I really believe, is a game changer in that equation. Active surveillance is a management strategy for men with lower risk, slow-growing prostate cancers, and it involves careful monitoring of the cancer with follow-up imaging and follow-up biopsies, and then treatment if and only if there's really a concern for the cancer getting worse and becoming threatening to a man's health. And that's really over the course of many clinical trials, over thousands of patients, been conclusively shown that it can spare men radical treatment, it can spare men side effects without compromising survival. So this is essentially the idea, if these are slow growing cancers, they don't really threaten a man, let's just keep an eye on it, not treat these, and only treat them if we have definitive evidence that it's something worse than we thought. So this is not something that we're talking about, this will be around in the future. This is the present. This is standard of care for men, and we've proven it works. So these are the current guidelines from the National Comprehensive Cancer Center Network, which is the network of all the largest cancer centers in the United States. It says that for low-risk patients, active surveillance is preferred for most patients that fall into this category, and not radiation, not surgery, just keeping an eye on these with active surveillance. So you definitely see in the lay press, there's been multiple reports and a lot of attention to this in the lay press, saying that this is now a normal part of a man's prostate cancer journey, is that, yes, we may have found cancer on your biopsy, but this looks safe to not treat this cancer, but just keep an eye on it. And that's really a critical change over what we were doing, decades ago. So what is active surveillance and what does it look like? So in the initial period after the first diagnosis and a biopsy comes back positive, we're going to recommend what are called confirmatory tests, essentially reassuring ourselves that we're dealing with what we think we're dealing with in terms of low-grade, slow-growing prostate cancer. That can involve usually a repeat biopsy in the first 6 to 12 months. It can involve an MRI to more closely look at the prostate to make sure we're not missing any disease. It can sometimes involve genomic testing, which can tell us if the cancer appears more dangerous than we can tell just by looking under the microscope. And then after that initial period of confirmatory testing, these men get followed. They can get followed with watching their PSAs, watching with digital rectal exams, repeating MRIs, and then repeating biopsies somewhere in the range of every 2 to 5 years to, again, keep monitoring and making sure we're not seeing worse cancer than we saw at the initial biopsy and worse cancer in diagnosis. And through that process, we can reassure ourselves basically that we're monitoring carefully, that we're not compromising the ability to cure these cancers. If we see something get a little bit worse, we're catching it before it can really become a problem. And so that's really borne out in watching the outcomes of these men over, again, thousands of patients over, multiple institutions over really, many, many years. So this is a study, that was from a partner institution. We've done similar studies here that essentially, if you manage men with low risk prostate cancer on active surveillance, follow these kind of protocols for prostate biopsy, the chances of the cancer spreading is 1% or less. The chances of dying of prostate cancer is 1% or less. So these cancers certainly can get a little bit worse where we say we need to pull the trigger and take care of them, but we're not compromising the ability to cure those cancers if we do watch them like this. So with that in mind, I'm going to turn this over to my colleague, Dr. McClure, and he can tell us a little bit more about some of the novel treatment strategies for prostate cancer.
Dr. McClure, you're on mute.
All right, perfect. Sorry about that all. So today we're going to talk about basically what we are doing at Cornell to help change some treatment options with regards to how we follow prostate cancer for men on surveillance, as well as how we may offer treatment options for patients with prostate cancer as well. And the first thing when we see patients with prostate cancer, a key component of prostate cancer management is risk assessment and determining if a patient is low risk prostate cancer, determining whether or not they're intermediate risk prostate cancer or high risk prostate cancer. Because as we've seen previously, management is really based off of that risk and determining how safe someone is to either be put on surveillance or be offered more definitive therapies such as radiation and surgery. And how we determine whether or not a patient's low risk, intermediate or risk or high risk is really based off on a couple factors. One is PSA values, and then the second is what the biopsy shows, so what the pathology shows. And we use those markers, the PSA and the pathology, to help patients and us make a decision on whether or not someone's a good option for active surveillance, whether or not they're a good option for radiation or surgery. And as Chris had alluded to earlier, patients with low risk or very low risk prostate cancer really should be offered active surveillance as that treatment option, because we know that it's safe and we know the risk of you missing an opportunity for treatment is exceedingly low. For patients with intermediate risk or high risk patients, the standard of care treatment for those patients really is treatment with either radiation or surgery. And then there's some investigation, us identifying patients who are what are considered favorable intermediate risk prostate cancer, and either be putting on surveillance. And there's also a evolving role for focal therapy, which is where we treat just one part of the prostate, as opposed to treating the entire prostate with either radiation or surgery. The reason for this is because we know that treatment has side effects, and those side effects are not like like when you have an appendix out and you just recover in the for a couple of days, then you go back to your normal quality of life that you had before. Treatment, unfortunately, has side effects with both sexual, GI, and urinary symptoms as well. And as this radar plot shows, which looks at impact treatment has on outcomes with regards to quality of life, you can see all treatments, whether it's surgery or radiation, have an impact on sexual function, urinary continence, urinary voiding function, as well as bowel function, in some cases hormone function as well. And that's where we're trying to approach prostate cancer management to better identify patients who may be candidates for surveillance, and if they are candidates for surveillance, do a better job at following them with new imaging approaches. And then we're also approaching these patients, or offering patients treatment options for focal therapy. One such imaging technique that we're using is PSMA imaging. And we know that MRI, as Dr. Hu had showed before, is a useful tool in helping us identify areas of prostate cancer on the prostate MRI. So this is a screenshot of what we call a fusion biopsy, where we've taken a patient who's had an MRI of the prostate, and then we do a fusion component where we do a real-time ultrasound as well. And then we take a computer, and that computer takes the MRI and fuses it to the ultrasound. And what we do then is target that specific area of abnormality that we see on the MRI, and we're able to sample that specific spot. And as Dr. has shown earlier, the higher the grade, or the higher the abnormality is on the MRI, the more likely you are to find prostate cancer there. But unfortunately, MRI is not perfect. And so we're looking at something called a PSMA PET scan, which is what these images are here. It's a tracer that targets prostate cancer. And what we hypothesize and what we think is that the cancer that matters, or the cancer that's really clinically significant, is going to show up on that PSMA PET scan, whereas the cancer that doesn't matter may not show up on that PET scan. We know that PSMA PET scans are very useful in patients with high-risk prostate cancer, or in patients who have prostate cancer who've already developed metastasis. But we don't know as a community yet is how useful this imaging is in localized prostate cancer patients, or in patients who are newly diagnosed with it. So we have a trial going on where we're using PSMA PET scans to help us better identify patients who've progressed from that low risk, kind of clinically insignificant cancer where you want to keep them on surveillance, versus the higher risk or intermediate risk prostate cancer, in which case you need to offer those patients treatment. And that's called, the trial is called ESCAPE. You can find some information on it here with this QR code, and you can learn about that yourself. I'm not going to go over it because of the interest of time, but that is one novel approach that we're doing here at Cornell to help better identify good patients for surveillance on prostate cancer. The second novel treatment options we're offering at Cornell is focal therapy for prostate cancer. Now, focal therapy is where you identify the area of prostate cancer on imaging and biopsy, and what you essentially do is ablate and destroy that tissue with some ablative process. And by doing that, you preserve the surrounding muscles and nerves that surround the prostate, so you minimize the effect of that of treatment. And you're essentially changing someone from intermediate risk down to a lower risk prostate cancer, where you can then continue watching them with surveillance. And we know that surveillance is safe and has minimal impact on quality of life. So the thought is with focal therapy is what we're doing is we are helping minimize treatment effects while offering a good oncologic outcome. Now, it's important to realize that focal therapy is still investigational. So it is something that if you are considering treatment, and it's important to be at least consider being part of a registry where we follow patients very closely, or be part of a clinical trial where you're investigating the use of these devices very scientifically and safely and ethically. We have been participated in 3 trials ourselves, and we are now currently running a trial called RETIRE, which is looking at an ablative technique called IRE, or irreversible electroporation, combined with a lower dose whole gland radiation therapy. Now, focal therapy itself exists in many options. And for those of patients who have investigated, you'll hear about HIFU. HIFU is where you use ultrasound energy to destroy the tissue. There's also approaches called cryoablation or freezing. And that's where we put needles in the prostate to kill the prostate cancer. Then there's other approaches such as IRE, which is irreversible electroporation. There's also other treatment options as well, but those are kind of the big players in the field right now. And if you're interested in finding out about the RETIRE trial, you can scan this QR code here to learn more about that as well. Thank you very much.
Thank you all so much. That was so helpful and so informative. We have a lot of great questions here, so I'm hoping that we can do our best to get to them. Someone here is asking, how accurate is the 4K test?
Chris, you want to take that one, or?
Yeah, sure. So I think a 4K test, like any test, has its strengths and its weaknesses. There's no perfect test that is going to sort of give you the answer whether prostate cancer is present or not, really. So a 4K test, so that the audience knows, is essentially a fancy newer form of PSA, basically. So it actually incorporates a couple of the tests we normally perform, which is total PSA and free PSA, along with another 2 variants of PSA. And that's the thing that adds up to 4Ks, basically. The 4K test gives a readout that is a percentage chance of finding significant prostate cancer on a biopsy. And so, you know, as you can imagine, it doesn't give you a yes/no answer that you're going to find prostate cancer. It may give something like a 15% chance of finding prostate cancer on a biopsy. So it's a reliable test in that setting, understanding that like a probability is a probability. Just because, you know, something is a 15% chance doesn't mean you're not going to be in the one of the unlucky men that's in that 15%. It doesn't mean you're going to be in the 85% that doesn't have it. And that's kind of, we use it often as one piece of the puzzle, along with the PSA, along with MRIs, along with rectal exams, to understand what is a guy's overall risk and need for a biopsy.
Yeah, because I think you're spot on. The advantage of the 4K is it's another tool to add to the picture to help us make a decision with the patient on the need to do a biopsy. And that's where I use it. I use it with MRI and 4K scores. I think that they are very useful to help understand that potential risk that you may have a PSA value that is concerning and needs further investigation.
Perfect. Thank you both. Someone else is asking, is a rectal examination of prostate seen as not useful anymore? It used to be a routine part of a physical exam.
Well, I'll speak to that very briefly. So yes, I think that in the pre-PSA era, as we talked about earlier, the prostate exam was a routine exam. And I think with the advent of PSA, and now more so that the professional guidelines or recommendations are that if someone has an elevated PSA, you get an MRI. And so in that context, we've seen that the use of the prostate exams has gone down significantly. When you look at the professional societies, that is the internal medicine or the family practice, even the urology societies, there are a few advocates for getting a prostate exam anymore. That being said, there are, as I mentioned earlier, some tumors that don't produce much, or cancers that produce much PSA, that you would have an abnormal prostate exam on first. And but having said that, there are a lot of prostate exams in which you may the examiner may think they feel something and it's a false positive. And so in that context, I think most of us are using a MRI if a PSA is elevated.
And is there any guidance on the frequency of a follow-up biopsy with a normal MRI and a stable but high PSA?
Chris, why don't you take that? That may kind of dovetail nicely with your active surveillance.
Yeah, I mean, that depends on if we're talking about a patient that's been diagnosed with a low-risk prostate cancer and we're following it with active surveillance. Again, there's no full consensus in the field for how often to do biopsies on active surveillance. The guidelines state it should be no more than one per year. Most people in the field feel that's probably too often, and every sort of 2 to 5 years roughly is enough. Now, if you're talking about a man that has had a prior negative biopsy and really doesn't, his PSA runs high, but there's nothing on the MRI, then, there has to be a good reason to repeat the biopsy, and that's something to discuss with the provider, why you would repeat it. We wouldn't just repeat biopsies sequentially in a man that's had negative biopsies, over and over again if we're not finding anything, basically.
And then to kind of piggyback on that, if repeated MRIs do not show any fast-growing cancers or changes in the prostate, is a biopsy necessary?
So I'll take that. I think if you're on surveillance and you have stable PSA kinetics and stable imaging findings, you still at some point will need to do a surveillance biopsy. You may decrease the frequency to which you do it, but particularly in the initial stages of surveillance, imaging is not 100% accurate. So it's inaccurate about 15 to 20% of the time. So just having a stable MRI is not enough to not do a biopsy, or having a negative MRI is also not enough necessarily to not do a biopsy in certain situations. So you have to look at the PSA value and the MRI and how those two work together.
Yeah, I'll follow up on that. Like, I completely agree. I think the fact is, I would answer that question by saying we can't forego the biopsies yet. And that's sort of because we don't know yet when the man whose MRI looks good or other imaging looks good, really that proves that the cancer is not progressing, because MRI is not a perfect test. So Dr. McClure's the PI of a trial we're doing on men on active surveillance, where we see what types of imaging we can follow along with biopsies to kind of get the answers to some of those questions. Is, do we see a future where an MRI is enough, at least for some men, or other types of imaging are enough, at least for some men?
So we have another question here that says, if it is true that some prostate cancers do not raise PSA, then should DRE or imaging technology be used to help with early detection? Are these non-PSA cancers generally or always not aggressive or low risk?
Yeah, so I can take that. So that's really a good question about the biology of the disease and the fact that it's not all one disease, that acts all the same way in all men, basically. And the question is 100% accurate. There are some prostate cancers that make very little PSA, so are poorly detectable with that. They are very, very much the exception. Like, we're talking about the kind of 1, 2, 3% of all prostate cancers that act like that. So we don't sort of, build screening programs to kind of try to chase that 1 or 2% that act differently, because we really can't sort of screen a large population for those rare outliers. But that being said, those are the ones where, yes, digital rectal exam and other things are more valuable in catching some of those cancers than PSA is sometimes.
Perfect. And then someone else is asking, how long does it take to get the ED function back after surgery-induced ED due to prostate cancer?
So, I'll take a stab at that, and Chris, I'd love it if you could follow up. So I think traditionally we've looked at ED recovery as something that plateaus 2 years after surgery. I think there are some studies that show that it possibly even goes on to 4 years, but really this is where the surgical expertise or the experience of the surgeon comes into play. I think that everyone always asks, so are you going to save the nerves? And that's usually a binary answer, yes or no, but there's a lot of that goes into that. Yes, there's a lot of differences in how people do it, and the surgeons that do it well, that minimize trauma to the surrounding areas, are going to have earlier recovery of erectile function. Those men who are earlier, for example, may have function intact within weeks of surgery or never lose it, whereas traditionally older men are going to take longer to recover their erectile function. So I'll let Chris elaborate on that as well.
No, I agree 100%. I think, it's going to take a couple of years. And I mean, the fact is, I mean, we've seen the data that Dr. McClure showed. There are some men, that just don't recover their erectile function well. And the two main things that go into recovery of erections after surgery are how good a nerve sparing we're able to do and how good a man's erections were before surgery. And age and sort of fitness level factor into that very much.
Someone else is asking, are there any updates on artificial intelligence aid in imaging diagnosis of prostate cancer?
Yeah, I mean, I can speak on that. There's certainly a significant amount of interest in looking at the use of AI and helping us better understand MRR and other imaging, but there's no real product right now that is being used that's kind of ready for prime time. But in the future, there will probably be a role for AI in helping a radiologist identify areas of concern and then either confirm or disagree with that computer finding. But currently, right now, it is not actively being used.
And is there any association in the development of prostate cancer associated with excessive consumption of diet sodas?
I think the silence you're getting says none of us know that that's an association.
Okay. Let's see here. Then we have another question. Can you explain the outpatient procedure known as Tulsa Pro, and what are some of the pros and cons?
I mean, that's the focal therapy. It's basically a procedure that uses they place a special catheter through your penis into the urethra, and then using MR guidance, burn the tissue with HIFU. And it's still, it is considered a focal therapy and would still be considered, investigational. It's not currently part of guidelines for management.
Yeah, I think that's an important point. I think Dr. McClure touched on this, but, focal therapy, we have a very good reason to think it could work and could be a very viable strategy to help men with prostate cancer, but we haven't proven it yet. So basically, these are considered what we would call investigational therapies, meaning we're still in the process of doing the clinical trials to prove that they work or who they work in, essentially.
I know that you guys all touched upon this a bit, but someone is asking, trying to figure out the best way to word this. For someone who has stage 4 after 70, or I guess, a later diagnosis, a more aggressive diagnosis at a later age. Kind of, what are some of their options? I know that you were discussing over treatment and monitoring, but I think they're wondering if they should perhaps consider looking into additional treatments, or if they should just continue with monitoring.
So
Well-
yeah, everything we've sort of talked about, focuses on men who have what we would call clinically localized prostate cancer, meaning cancer that's in their prostate. If a cancer has spread, then it is much more dangerous in a much shorter time frame. So even with older age, a cancer that has spread could threaten life within 5 years or something like that. So yeah, once we see a cancer has spread, we do recommend at least consultation for considering treatment of that. And so that's a little bit different than the localized cancers we were more talking about.
And does having BPH, BPH make it more likely that one has or will have prostate cancer?
No, it's completely independent. They're two separate things.
Yeah. Some people may argue that, and the only reason why some people might argue that you do is just because that person's symptomatic, so they're seeing a urologist and or their provider, and they're getting screened. So they're completely separate things.
And is there any research to quantify if prostate cancer is an inherited disease?
Chris, why don't you-
Sure, I got it. So yes, there is prostate cancer has actually quite a strong heritable component. So one of the major risk factors is if first degree relatives like a father, a brother, have had prostate cancer, men are much more likely to have prostate cancer. Now, although there is a strong heritable component, it's also not so strong that having a close family member that has prostate cancer means that another man is going to get it. It's not that strong, certainly. So we do recommend earlier screening for men who have family history of prostate cancer. And that's the main way we sort of change management.
We have another question here about a Decipher test and a Decipher score. What is the usefulness of the Decipher test? And also, just to the person who asked the question, I know you gave some specifics. Unfortunately, we can't address those on the webinar because our doctors would need additional information to, fully give you an answer to your question. But if you're interested in making an appointment, I would suggest doing so. But if we can just talk about, what the usefulness of the Decipher test is.
Chris, you want to take that one?
Sure. So, I think this relates more broadly to a question that came up otherwise, is how do you determine whether a prostate cancer is low risk, intermediate risk, or high risk? And so first, the grade of the cancer, which is how abnormal things look under the microscope, is arguably the most important thing telling us how aggressive a prostate cancer is. That's reflected in the Gleason score, where the lowest grade cancer is a Gleason 6, or in a newer, simpler scoring system that's called the grade group 1. And then in that newer, simpler scoring system, that the grades go from 1, which is the bottom, to 5 at the top, which is very aggressive. Other factors looking at how much cancer we found on the biopsy. So when we take multiple shots into the prostate, we can find the entire prostate is filled and every single needle hit cancer. We can find the opposite, and just one tiny little bit of cancer that one needle hit. The PSA level, the higher the PSA is, most commonly that's correlated with the total amount of cancer that's there. So those are all factors that go into determining, low risk, intermediate risk, high risk. The Decipher score is what's called a genomic test. It's testing the tissue that we take from those biopsies and looking at the genes that are expressed by the cancer itself to determine whether it seems like it's a little bit less dangerous or a little bit more dangerous than we can tell just by looking under the microscope and assigning the grade. So, the Decipher score, it's sort of, again, one piece of the puzzle in defining risk. It does not, we do not use it just by itself. It's one other test that's a piece of the puzzle. But when there's sort of a cancer that's maybe kind of in the gray area, it can be a tiebreaker of sort of, does this seem lower risk or higher risk to determine what to do about it.
And it can also help guide our colleagues in radiation oncology make a decision whether or not they want to give an additional therapy called hormone therapy during radiation therapy as well.
We have a good question here. Someone's asking, are there any symptoms a layperson should look for before reaching out to a physician or to help monitor for prostate-related risks?
I mean, I think we talked about, so I think Chris mentioned earlier, BPH, as you get older, your stream may be weaker. Typically, a lot of men will say I wake up at night to urinate more frequently. That's an overactive bladder. And so again, those are separate diagnoses, and prostate cancer will not have any symptoms until it's we had the example of stage 4, and stage 4 just means it's metastasized, right? And so if you have symptoms of weight loss, and this is true of other cancers that may cause what we call cachexia, I mean, that's a prostate cancer that's already metastasized. So localized prostate cancer, we're still curable, will not have any symptoms. And therefore, that's why you have screening tests like PSA to try to find these cancers before they become symptomatic.
Is there a PSA threshold for moving from active screening to active intervention?
I think, Chris, maybe that's the PSA threshold for active surveillance to definitive therapy.
Yeah. I would say the short answer is no. A continually rising PSA on a man on active surveillance can indicate that the cancer is getting worse and that we should sort of pull the trigger and take care of it. But again, that's usually only one piece of the puzzle, and we're rarely going to act on just the PSA alone. In fact, during active surveillance, the PSA is usually the least useful test we have that we're monitoring. And instead, the patient's MRI and a patient's repeat biopsy, if we see those things getting worse, those are things where we're more likely to say, okay, we need to pull the trigger and take care of this cancer. And the PSA rising can sometimes give us a hint that that's what we're going to find on a repeat biopsy. And that's how I would describe it.
Someone else is asking, are there any particular DNA mutations associated with prostate cancer?
Yeah, so this is my wheelhouse again. So in terms of the genetic of prostate cancer, so we separate things into what are called germline mutations. These are the things that you can get from your parents and that you can pass on to your kids and confer familial risk. So in that regard, the things that are associated with prostate cancer, and specifically with more aggressive prostate cancer, are actually genes that are most commonly associated with breast and ovarian cancer in women. So BRCA genes, particularly BRCA2, is associated with more aggressive prostate cancers in men that are carriers of that. There are other genes that are closely related to those and do some of the same processes in DNA repair that are also frequently mutated. There are some genes that are involved in other processes to repair the DNA in different ways that are actually also associated with colon cancer and other cancers referred to something as Lynch syndrome, which is a small percentage of the time that can confer prostate cancer. These are things that we do commonly test for now and have simple blood tests for in our clinic for men that either have aggressive prostate cancers or that have a family history of either prostate cancer or other of these cancers that run in the families that might suggest that their cancer is sort of a part of this syndrome that implies there are mutations there.
Perfect. So So I know that we're just about out of time. I'm sorry that we couldn't get to all the questions, but thank you all so much for so much great engagement. There were multiple questions regarding tonight's recording. Yes, tonight's recording will be sent to everyone in the next couple of days. We will also include the link to this QR code as well as the phone number. So we thank you all so much for joining us tonight. To our wonderful panelists, thank you for such an engaging and informative presentation. I think this was so helpful for so many people. We really appreciate your expertise and your time tonight. And to all of you who joined us, thank you for spending your evening with us. And I will be in touch via email in the next few days. Have a great night, everyone.
Thanks, everyone.
Have a great night. Happy Thanksgiving.
Happy Thanksgiving.